Welcome to our March So What seminar. Today we wanted to speak about what does the evidence tell us about preventing mental health difficulties in children and young people. Before I give us a bit of an introduction, I just wanted to talk through some housekeeping points. So just to let you know, if you want to access them, there are closed captions available if that's helpful to you. Also, we've disabled the chat, but there is the Q&A function. So if you have any questions you'd like to put to any of the speakers, please do pop those in the Q&A and we'll pick them up. There'll be a panel section at the end where we'll be picking some of those up. So also, if you've got any technical issues you're experiencing, you can also put those in the Q&A and some of the team will pick those up. The session today is being recorded and will be available through the Anna Freud YouTube channel if you want it afterwards. And we will be sharing the slides, I think, as well. Also, just to let you know, sometimes when we're talking about mental health, the topics can feel a little sensitive. If you find anything particularly distressing or triggering during this seminar, please do feel free to step away for a period of time or to leave. That's absolutely fine. But also be aware that if you do need support, there should be a link in the chat that you can follow to help with that too. I think that's everything housekeeping wise. So if we can move to the next slide, I'll just walk you through the timetable for today. So I will just continue with an introduction for a little while, and then Julian and I are going to set the scene in terms of the prevention landscape and also give a little flavour of some of the research that we've been focusing on in this area before we hand on to some great colleagues that we work with in other organisations to talk about some of their prevention activity. So Dan Hayes will be talking to us about help-seeking interventions for young people, and Jessie Foyle will be talking about a model of prevention around mentoring that the West Ham United Foundation have developed. And then we'll have time at the end. We'll have a panel which will include the speakers and a few others who we'll introduce in a minute, and plenty of time to discuss any questions that you have for that panel. And then we'll just wrap it all up with a few reflections, and that will be the end. Great. Okay, on to the next slide. So this is just to set a little bit of context for those of you who haven't joined So What seminars before. First of all, we should introduce the people who are with us. So can I just ask those named here just to pop their cameras on just for a brief minute, and I'll ask everyone to introduce themselves. So I'll start, and then perhaps people can just go around in the order that they're on the screen, if that sounds okay. So my name's Jess Dayton. I am Director of Applied Research and Evaluation at Anna Freud, and I'm also a Professor of Child Mental Health and Wellbeing at UCL. And stitching those two different institutions together, I'm Director of the Evidence-Based Practice Unit, which is essentially an applied academic unit that sits across both Anna Freud as a child mental health charity and UCL as a university. Julian, would you like to go next?
Thanks, Jess. Hi, everyone. Thank you for joining us today. My name's Julian Edward-Childs. I'm Head of Evaluation here at Anna Freud, and I'm also Professor of Evidence-Based Child and Adolescent Mental Health at UCL. And like Jess, stitching those roles together, I'm a co-director of the Evidence-Based Practice Unit. Dan, please.
Everyone, thanks for joining. I'm Dan Hayes, Senior Research Fellow at University College London and Senior Research Fellow also at the Anna Freud National Centre for Children and Families.
Good evening, everybody. Yes, thanks, Jess. Hi, everyone. Jessie Foyle, Director of Programmes at West Ham United Foundation. I oversee our work across education, employability and youth and community. And that includes some of our mentoring services, which I will be talking about later.
Hi, I'm Thea. I'm a young champion at Anna Freud. I'm 21 and I'm like the lived experience expert for experiencing mental health issues.
Hi, I'm Martha. I'm the Programme Coordinator for Applied Research and Evaluation here at Anna Freud, and you'll be hearing more from me when we get to the Q&A.
Be hearing more from you too at that point, Thea, won't we? So that would be great. Good. Right. So just to give a little bit of context then about the Evidence-Based Practice Unit, which Julian and I have both mentioned. We are, as I said, a sort of collaboration really across Anna Freud and the Faculty of Brain Sciences at UCL. And our remit is really to bridge the sort of worlds of research and practice to better, I suppose, find solutions to challenges around supporting children's mental health and well-being. Within Anna Freud, we have a collection of researchers. EBPU works particularly closely with what used to be a separate organisation, but now is housed with us at Anna Freud, the Child Outcomes Research Consortium, which is the UK's leading membership organisation, collecting and using evidence to improve children and young people's mental health and well-being. And some of the projects that we'll talk about today, we very much work on alongside colleagues at Cork. Next slide. And each year, the Evidence-Based Practice Unit produces what we call our Key Findings Report. And so every year, one of these So What seminars focuses on that report, but it's available. We like to think of it as our Christmas present to ourselves and indeed to everybody else. But it's essentially a collection of our findings from across the year. So we'll have another one this December, but you can see the back catalogue on the Anna Freud website. So just to let you know, that gives you a bit more of a flavour of the kind of things that we do. Great. Okay, so we're now going to move on to a bit of context setting around prevention. So Julian, I'll hand over to you to kick off.
Thank you, Jess. And once again, thank you all so much for joining us here this evening. To get us started today, Jess and I wanted to talk about the prevention landscape for children and young people's mental health and some examples of how we are addressing this in our research projects. And here I just wanted to set the scene, and I'm sure you'll be familiar with many of the kind of facts and figures I'll be going through. But clearly mental health difficulties affect both the individual, family and society. And mental health, neurological and substance use disorders make up 10% of the global burden of disease. And if you focus on non-fatal diseases in particular, this increases to a whopping 25%. The graph you can see on the middle of the screen shows going up on the y-axis the percentage of young people with a probable mental health disorder. And this information is taken from the National Children and Young People Survey that's published by NHS Digital. So we can see the years going from 2017 to 2023 going across the bottom on the x-axis. And what this is telling us is that mental health difficulties were affecting about 12% of children and young people in England at the bottom of the line in 2017. Last year, however, at the top of the line, it was more like 20% of children and young people. And we know that experiencing mental health difficulties during childhood and adolescence can really have lifelong impacts. So, for example, we know that about 75% or 3/4 of adults who experience mental health difficulties actually first did so by the age of 24 years. And if you go down to 14 years, 50% of adults who experience mental health difficulties first did so by this age. On the next slide, I just wanted to think about some of the challenges we know from mental health services in meeting the existing levels of need. And here we're just kind of contextualizing this challenge against the rising levels of demand for mental health support. So in this figure, it shows a number of people going up on the y-axis and time going across the bottom from 2016 to 2023 on the x-axis. And what this is really just illustrating is on the top line, we can see the increasing numbers of adults in contact with mental health services. And similarly, we see an increasing number of children in the bottom line in contact with mental health services. So yeah, here I just wanted to kind of give us some background information about the kind of landscape of mental health difficulties before I pass back over to Jess to take us through the next few slides.
Thanks so much, Julian. Yeah, so if we move to the next slide, essentially what we can see from the picture that Julian just presented to us there is we've got a sort of incremental increase year on year for quite a long period, and probably actually predates some of those data from 2017. There was already an increasing trend in mental health problems for children and young people before that, and it seems to get slightly worse year on year, or that has been the picture, or it's either that or it's stayed sort of stubbornly high. We don't have increasing at the same rate the availability of mental health services. So we can see the increase in contacts there, but the reality is when we talk to many services, they feel very stretched. We hear stories all the time about waiting times for specialist mental health services. So as much as we can put more resource into that, we also have to think about getting further upstream of the problem really, and trying to actually prevent those problems escalating in the first place. Otherwise, what we'll see is more and more need at the high end and a real struggle to be able to meet that need because it takes much more extensive resource. So the idea behind prevention is very much to sort of start at the root before either very early in the stage of the problem or before problems begin to emerge, to see if we can prevent those mental health difficulties sort of surfacing in the first place, with an aim to essentially help children and young people feel just generally healthy and happy and able to function well, but also to reduce that picture that Julian was describing of the longer term impacts, not just on mental health in adulthood, but also just generally ability to sort of function in later life. And also to create an environment where we're talking about building positive mental health, and we're empowering children and young people and their families to think of themselves as sort of more in control of building positive mental health and well-being for themselves and those around them. Next slide, please. So, I mean, that all makes perfect sense, and there has been a lot of work in this area for a while, but nevertheless, we're still seeing the prevalence rates increasing. So there's something about what we're doing or not doing which isn't quite tackling the scale of the problem. So we must not quite be approaching this the right way, or maybe just not enough of it. So kind of thinking about what is the root of this problem that we don't seem to be able to get good models of prevention out there. There's probably a few key aspects. One is gaps in knowledge. So it's true to say that we know a kind of wide range of school and community-based prevention programs, and some based in families as well, that have been shown to be effective in preventing or reducing mental health problems in those sort of early stages. But the evidence is still very mixed. We know that some things work in some contexts and not others, and we also know that there's a whole variety of effective practice but also quite ineffective practice as well that happens, and the evidence-based approaches don't necessarily get used as much, or it may be that we have possible promising interventions but they're not evaluated rigorously, so we don't know. So those are the gaps in knowledge, but there's also gaps in implementation. So even those things that we know work don't often get rolled out in a widespread fashion. And if they do, sometimes they don't stay. Also, there is a challenge with prevention that sometimes we don't, we can take universal approaches, but if we want to sort of target our support to the people who might most need it, who might be most at risk of having emerging mental health problems, we're not always clear the best way to target those people. And also it's very hard to prioritise prevention, particularly when we know there's escalating need at the very high end of the spectrum. So sometimes we sacrifice the prevention focus in order to deal with where the sort of major issues are, and it's quite hard to sort of justify that focus. Next slide, please. So in terms of tackling some of those gaps, some of those problems, it's a lot of the work that we do at the evidence-based practice unit is about thinking about how we can improve the knowledge, how we can improve the implementation and the prioritisation of prevention. And a lot of this work we talked about previously in some of these So What seminars. So you'll see the numbers that are on the slide here and on previous slides, in fact. A bit later on in the pack, you will see links to previous YouTube videos of our So What seminars and some of the reports and things that we've written on these topics. So So the first three we've covered quite a bit, but just to sort of summarise here, some of the key things that we've been focusing on are supporting young people to be who they are, so to talk on their own terms about their mental health, and to really empower them to have a voice in conversations about what building good mental health looks like and protecting their well-being looks like. And as I say, you'll be able to see links to some of that in a minute. Also enabling young people and those around them to identify needs at an early stage. So there's a whole range of activity that we've been doing around this. And it's part of sort of some development work that we're also doing, thinking about what are the early signals that might not just be about mental health symptoms, but might be about how we know if somebody's struggling, that we can identify so that we can get help sooner. And also recognising that social support and social connection is a really important aspect of prevention. When we talk to young people, they talk a lot about connections with friends, with family members, sometimes with people at school, even with pets. They talk about those connections being really meaningful and helpful to their mental health and well-being. The aspect that we wanted to focus on, to give a couple of examples today, though, was about bringing support to children and young people where they are, so within the context that we find young people in their communities and in their schools. So if we go on to the next slide, I'll just say something about the first example, which is Be Well. So Be Well is a programme, it's a collaboration between Anna Freud, the University of Manchester, and the Gregson Family Foundation. It started in 2019, and it's very much about empowering young people to have a voice, to talk about what should be prioritised in order to improve their well-being. And it's about trying to use that voice of young people to pivot the system to better focus on well-being, particularly in school contexts where sometimes there can be excessive pressures to focus on educational outcomes and perhaps, you know, well-being as a sort of secondary concern. So central to this programme is a large-scale survey. We started in Greater Manchester in 2019, and we worked with the whole of the 10 local authorities within that combined authority, and their young people. So that initial process, we spoke to over 350 young people from a whole range of different schools, talking about what they thought represented their well-being, what kind of aspects of their well-being were important to capture, and also what were the drivers of their well-being in terms of everything from eating to sleeping to friendships to exercise to a whole range of other sort of activities and support networks. So we collated all that information, developed a survey which has now been embedded in schools across that whole city region, and the questions that we asked in that survey were sort of developed with young people, and we have also now moved to a new area, which is Hampshire, the Isle of Wight, Portsmouth and Southampton. So it's completely the other side of the country, but we've now reached over 85,000 young people who've all been able to give their voice and respond to these surveys, talking about their own well-being. And the idea is that it's not just a survey, it is something that should be used in a very sort of proactive way. So the whole ethos of the project is to listen to the voices of children and young people, to act on what they have said, and to celebrate any sort of positive wins in that regard. So just to give some kind of example of some of the things that has been done in terms of that sort of acting on the data, if you like. Just if we can move to the next slide, I'll give some examples. So what happens is we carry out the survey every year, and the findings, we give sort of headline reports on what the findings are telling us, but also each school that's involved in the programme does also receive feedback about their young people in their school and how they're feeling and experiencing life and their well-being. So there's a range of ways in which we can respond to the findings that come out of the survey each year. And young people have been able to benefit from this process in terms of being able to become a Be Well champion. So they become part of the programme almost, and they can be involved in things like social prescribing activities, where they have a commissioning pot themselves and they can commission services around social prescribing to support other young people. We've also had young people involved in analysing the research. I won't go through everything on the slide because there's just too much. But also, even at a strategic level, we've had for example, the Greater Manchester Combined Authority has been building in the findings from Be Well to its strategy going forward to think about how it supports its young people. We've had schools actually targeting the support that they provide in the school based on what the survey results have told them about the strengths and needs of their students as well. And there's a whole raft of other things besides going on all the time with the data. But it just goes to show, I think, that data can seem like a very far removed and quite dry kind of means to understanding and acting, but actually, and this has been sort of beating heart of this programme, and it's really kind of empowered the voice of young people and helped us prioritise their well-being. I'll pass back to Julian to give the second example.
Thank you, Jess. So I wanted to introduce on the next slide a project called On the Way to School. So we're involved in this project. It's being led by colleagues, some of whom are on the screen. And I wanted to talk about this project because I think it's a nice illustration of well-being and kind of prevention programs that really do quite literally go to where children and young people are. So please do check out the website for further information about who's involved in the project and what we're doing. But moving on to the next slide, please. The project is looking at active mobility interventions to and from school. So this simply refers to travelling to school using physical activity, so like walking or cycling. And we all know that physical activity is crucial for healthy and active lifestyles, but we also know that not everyone everywhere has affordable access to physical activity. And we think that these active mobility interventions to and from school hopefully provide a chance to encourage healthy and active lifestyles in a way that's going to fit into what children and young people are doing in their daily lives, and also where they are. It's not something they have to kind of go to, as it were. But also such programs have benefits for the surrounding environment in terms of congestion, noise, and air pollution. So moving on to the next slide, please. I'll just introduce the overarching aim of On the Way to School. So what we're trying to do is to look at the acceptability and impact of these active mobility interventions to and from school. And we want to look at the accessibility and impact in one area. And then we want to see if we can kind of transport and implement those interventions based on what we've learned into a different context and environment. And I just wanted to, before I describe it anymore, touch on some of the principles that I think hopefully you'll see coming out of this project. And really it does focus on inclusively involving children and young people and working with them and their communities in delivering the work. The project spans diverse countries, environments, and professional groups, and it seeks to redress the health equity gap, particularly by implementing these health enabling interventions in settings and communities that might traditionally be considered as underserved. So on the next slide, I just wanted to illustrate where we're doing the project. So first of all, the team is working in Colombia to assess and evaluate 2 pre-existing active mobility interventions. So these are walking to school and cycling to school, and the cycling to school program includes learning to ride a bike, importantly. Both of these programs have a real focus on road safety, so that children and young people, although they're kind of guided in these programs, so that they're building and learning kind of these daily life skills that will benefit them beyond the scope of the project. So although these interventions have been used for some time in Bogota in Colombia, we want to do take a closer look at the experience, implementation and impact of them. And really, we want to then work with our colleagues in Mozambique to think about, okay, how's it been in Colombia? How do we take learning from that and implement the best fitting one in a way that's going to be appropriate in this different context and in this different setting? So the next slide just presents a bit of a summary of what I've been talking about, but I just wanted to highlight that an important part of this project is really examining how implementation works and what factors that we might not necessarily consider are important across these different settings. So to illustrate this, one thing that really kind of caught my interest when colleagues from Colombia were talking about the work is that they were saying how the interventions can help address gender inequalities. And they talked about how, for example, in their surroundings, girls were much less likely to have opportunities to learn to ride a bike and to have opportunities to cycle. So I thought that was really interesting to see a kind of positive unintended consequence in helping to address gender inequity using these programs. On the next slide, I just wanted to echo what Jess had been saying earlier. And when we're talking about mental health and prevention, we're not just talking about mental health. And on the way to school, we're collecting different types of information to really try and get a well-rounded picture of children and young people. So children and young people are supported to complete a survey on physical and mental health, but we're also using different tools to capture things like intensity of physical activity, stress and exertion, GPS location to look at kind of where these routes are taking them and how far people are going. Things like height and weight, but a really important aspect of the data collection in this project is an app called Our Voice. And this is used on breaks during these trips so that the children and young people can stop and take a picture, record a voice note, but they can capture their experiences during the journeys. The final part that I wanted to say that we're looking at in these different data collection tools is also the role of building relationships with peers through these group active mobility interventions. So I think those are the main parts we wanted to cover. On the next slide, we've got the links and the resources Jess mentioned. So yeah, if you'd like to follow up on anything that we've been talking about, our research projects within the prevention landscape for children and young people's mental health, please do check out these links. Yeah, obviously feel free to reach out to us during or after today's session. And I think I'm now going to hand on to Dan. He's going to take us on to our next talk about help seeking and young people. Thank you.
Hi, everyone. Thanks for joining. So you have me for around the next 10 minutes or so. And today I will be giving an overview of a review that I completed whilst at the evidence-based practice unit, looking at the impact of universal school-based programs on help seeking for young people. Next slide, please. So just a bit of background to help situate ourselves in the research. So universal school-based programs are thought to help with mental health difficulties and preventing mental health difficulties. And that's been covered previously. But what we wanted to touch on here was what we mean by universal. So these are whole classes or whole schools where programs are delivered to young people. So that is that they are for everybody, rather than being targeted to specific individuals with potential high risk of developing mental health difficulties or already have mental health difficulties, i.e. are clinical. In particular, interventions which target help seeking have rapidly increased in the last 10 years. Reasons for this may kind of tie in with some of the work that Jess was talking about earlier and the research with regards to the increases in prevalence rates and how to help young people get help early on or when they first start experiencing symptoms. And these help-seeking interventions work in a variety of ways and can help young people get help from a variety of sources. So this could be different types of trusted adults, such as parents, GPs, as well as friends or teachers. However, recent reviews have produced mixed findings. They have, and we think that this might be due to some methodological limitations. So really around focusing on behavior rather than kind of intentions to help seeking, as well as not splitting down help seeking interventions into their different constructs. So looking at the difference between intra help seeking, which would be focusing on the self, versus interpersonal help seeking, which would be focusing on helping others get support. Based off of these limitations, we decided to conduct a review to look at the impact of help-seeking interventions for youth in school-based settings. And one thing that we decided to focus on as part of this was looking at effect size. And what we mean by effect size is a lot of the research to date had focused on significance level. So was there a significant difference? You could say yes or no. However, we didn't really know the impact of that intervention on the individual, just that there was a difference to those that didn't receive help. Next slide, please. So this just gives a brief overview of what we did. I won't stay on this slide too long. So we undertook a systematic literature review. And as part of that, we focused on the routine databases that we usually do as part of a project like this. So PsycInfo, Medline, Embase, Cochrane. We also looked through included papers and their references to see if we could pull out any more papers. In addition to the academic literature, we also looked at reports which could be beneficial, as well as consulted experts in the field. Following that, we whittled the papers down to find the ones that we were interested in. And then at each stage, we double screen these papers. So there are at least 2 people involved in the process to make sure that we weren't being biased with our results. And then we also double extracted the data at each stage to, again, reduce the risk of bias. Next slide, please. So what do we find? I think the first thing to know, and you might have noticed it on the previous slide, is actually there were 33 studies that met inclusion criteria. However, this slide says 14, and the reason behind that was that actually in terms of the 33 that met inclusion criteria, only 14 had sufficient data to be able to determine effect size. This was after we had contacted authors, the majority of papers that we wanted to include, where we weren't sure if we could include it because of differences with data or missing data. The 14 that we ended up with were split into 7 different constructs for help-seeking behaviour. This included the most common ones, which we kind of expected, which were intended help-seeking, and then also actual help-seeking, in which there were 6 and 8 studies respectively. Other constructs that were picked up on in this review included help-seeking confidence, help-seeking stigma, and there was also a combined construct of mental health first aid and intended help-seeking, and each of those had 1 study which focused on those each. In terms of the results going forward, I'll just focus on the ones where there were multiple studies involved. So the first one that we just wanted to talk about was intrapersonal intended help seeking. And what we mean by intrapersonal is help seeking for themselves. So the young person seeking help for themselves. There were 4 studies, and what we wanted to also do was split this up into what was the effect size or the effect of the intervention straight after the intervention was received, as well as was there any difference at longer term follow-up, and what was that effect. So at the end of the intervention, there were 4 studies. There were quite mixed findings here. So 2 studies showed a fairly small effect size. So there was some evidence that it was helpful. 1 study showed a negative effect size, but this was a very, very small negative effect size. And 1 study varied depending on who the intervention deliverer was. And this was either a teacher or a clinical psychologist. And then in terms of longer follow-up, only 2 studies looked at this from the original 4. And these follow-ups were at 4 and 6 weeks later. Effect sizes were similar to what was demonstrated previously. However, on 1 study, there was a slight increase and the effect size was negative and had grown. Next slide, please. Another construct, as outlined before, was intrapersonal attitudes towards help seeking, and that's kind of attitudes towards helping others. At immediate follow-up, so straight after the intervention, there was only 1 study that looked at this. However, a large effect size, or very large effect size, was found, and this was on perceptions of helping suicidal peers. However, 3 studies looked at longer-term follow-up, which is quite interesting, given the fact that immediate follow-up wasn't looked upon. However, there was quite consistent results within this literature, which showed that there was a small to medium effect size of between 0.24 and 0.38 at between 3 weeks and 3 month follow-up. And then lastly, the other construct where there was enough data to kind of make some assertions around was interpersonal attitudes towards help seeking. So help seeking towards the self, or attitudes around that. 4 studies reported on effect size. Again, this was very, very mixed, and we couldn't really pull out a lot of different reasons for this, although there are a couple on the next slide. And then follow-up very much was at 3 and 6 months later, and very much mirrored the individual effects, which the follow-up effects, which suggests that initial results were sustained at this 3 and 6 month follow-up, but reasons for this were quite unclear. Last slide, please. Thank you. So just to try and sum up what we found here, again, whether some of it is a bit dry, there was preliminary evidence to suggest that interventions regarding targeting interpersonal attitudes had a temporary medium effect on young people. We said temporary as this was not very much in terms of a longer term follow-up, so we don't know the longer term effects of this. However, for the other constructs looked at, it appears that effect sizes were mixed. However, in both different constructs, there appeared to be some kind of agreement that where there was a small to medium effect size, this was around kind of older adolescents or older teenage years, so really between 15 and 17. But this wasn't necessarily found in the slightly younger age groups. And we've suggested that reasons for this may be around kind of more independence with older kind of teenage years, and therefore they're not reliant on others such as parents or guardians in terms of their help-seeking behaviour. That being said, there are some methodological issues in the field which warrant discussion. Obviously, as outlined, a lot of the data wasn't available, so we only have a subsection of the 33 studies to calculate the effect size. A lot of the measures were self-created, so we don't have very robust measurements, so we don't really know often if these studies are looking at the exact same thing. More importantly, however, are the last 2, and one is that a lot of the studies did not focus on fidelity to the model, so therefore we don't know how closely the intervention was followed. It could be that those with greater effect sizes more closely followed the intervention. And also, more importantly, this was very much looked at an individual level, and therefore it doesn't really target kind of the wider structural barriers which could be at play, particularly what we know in terms around growing kind of health inequalities and the social determinants of health. It's not on the slide, but based off of these, we are kind of refining some of our work to try and understand how to best help young people with help seeking. And as part of this, we are launching a program of work called Enact, which is kind of bringing together schools and community organizations to help implement social prescribing via schools to see if this can work as an early intervention strategy for young people's mental health and well-being. That's all from me, and I'll stop there.
Thanks, Dan. That's great. Rather illustrates the point about the gaps in knowledge when you see how quickly that many hits comes down to a very small number of studies. Thank you. Right, so next I think it's over to you, Jessie, to talk about West Ham United Foundation and the work you've been doing around mentoring.
Yes, thank you very much. Really good to be here, and really exciting to, I guess, share a bit more insight and information on a particular project that we run at the foundation. First thing to say is it's a terrible name, and we're actually on the lookout for a name. So if anyone's got any suggestions for an impactful project name apart from PCN mentoring, I'd be open to that. Next slide, please. So just to set the scene a little bit for those, I guess, of you who don't know or aren't aware of some of the work that not just we do at West Ham, but also wider across the kind of football club network. West Ham United Foundation, we are a charitable foundation, but we are essentially the community outreach arm of the club. So we have kind of, we're linked to the club, and we certainly kind of deliver under the brand, on the banner of the club, and we're very much kind of interlinked with the club, although we do have our own separate vision, mission, and objectives, as you can see there on the table, on the slide, sorry. And just to kind of, again, a bit of kind of context, within our network, we have across the kind of nationally, across professional football clubs, there are various kind of trusts, foundations, community work going on. So if you're not linked in with those networks, I would strongly kind of advise having a look at see what's happening locally. And in terms of kind of London, and certainly in East London, that's kind of where we're operating. And as you can see there, our vision, our mission as an organisation is to try and utilise, I guess, certainly our unique place within community, and certainly within the East London community. Kind of linking into some of those roots in terms of where the club kind of was established from, but really kind of working in partnership. And we see ourselves as certainly an anchor institute within the East London community. And ultimately, it's about kind of helping people. Yes, some of that is around engaging people through football and sports, but that's definitely not exclusive to what we do. So we do a huge amount and variety of different work. And in terms of those 3 points there around kind of opportunities, pathways, and changing lives, we kind of see that as a bit of a pyramid. So actually around opportunities, it's around creating opportunities for local communities and people within those communities. And then within those, there will be pathways for some individuals. And then at the top of the pyramid, hopefully we're having a positive impact on people's lives and changing lives. And in terms of our objectives, one of those just at the top there in terms of responding to local needs. So we very much approach our work from a needs-led perspective, and that's essentially where the seeds of this project came from. So if you go to the next slide, please. So in terms of our PCN mentoring project, originally it came out of a conversation with a local GP, Dr. Fazana Hussain, who's absolutely inspirational lady, and she was essentially sick and tired of having patients from her GP surgery affected or directly affected and negatively affected by youth violence. So although this is not specifically targeting mental health, which I appreciate is the kind of, I guess, the theme for today, actually we know there are significant links between youth violence and mental health and those communities suffering from those. And essentially, Dr. Hussain was looking to do more and looking to kind of help her patients. She'd kind of known young people who have kind of died from stabbings and violence. And it was just kind of looking to the kind of community and partnerships to do more about what we can do in terms of preventing some of that from happening. So off the back of that conversation with Fazana, we kind of developed a model that we kind of piloted. It's probably 2021 it actually started, so there's a typo on this slide, but it started kind of November, December 21. And it's around, I guess, kind of utilizing some of the unique assets that we bring in terms of our community networks, and I guess the ability of us as an organization and the brand of football to engage with young people, but also linking that in with local GP surgeries. So through the primary care network, the PCN 1 in Stratford, we established a pilot. Next slide, please. And just to give you a bit of a sense of kind of where we are up to currently. So that, as you can see there, the pilot was established in 21. Our first young person was referred into the service at the end of 21. We've subsequently continued that pilot. We've done some evaluation in terms of the impact, which I'll come on to in a second. And bringing us up to date in terms of where we are today, we are now looking to extend and expand the project into some new locations within East London. And we are working with Anna Freud Institute to run a evaluation of that, so a kind of a deeper evaluation across the next 18 months. Next slide, please. So just kind of, I guess, taking it a step back as well in terms of where it started. And again, in terms of responding to local needs and community needs, it was looking at those affected or at risk of violence in terms of young people. The funding that we've unlocked through the London Mayor's Office, through the New Deal for Young People, that's allowed us to put in place the extension and expansion of the pilot. But we also recognise there is a significantly diverse and young population, particularly in East London, and actually kind of how we're engaging with those communities, certainly those that are underserved, is key to a lot of this work. And we're looking really at that kind of public health approach to how we can kind of put in place interventions and support with kind of networks to help with the youth violence reduction agenda. Next slide, please. So in terms of the actual model, we have our youth mentors or youth workers. We kind of, within this project, we kind of use those terminology interchangeably. But so within our project, we have a youth mentor based at the surgery, and they work across. Currently, they work across within the Newham pilot that is split into 7 different GP practices across Stratford in Newham. And the youth mentors work with young people who have been referred to them via the GPs. So the GPs kind of through their patient networks, they will then look to see if they feel that they have a young person suitable for the service. And currently the eligibility is fairly broad, so which is an element that we're kind of working on refining and looking into that. But as I mentioned, the seeds and the seeds of this project came from kind of a knife crime perspective, but we've kind of recognized that actually there's a broader piece around youth violence. So really the eligibility or the target young people that we are looking to engage with are those at risk of youth violence. They're referred in to our mentors through the GP through a fairly straightforward referral process. And then they receive an up to 6-month support of mentoring. Next slide, please. So as you can see from the kind of the fairly simple, kind of straightforward step-by-step, crucially, the youth worker connects with the young person, typically within the surgery, so it's a place known to the young person, and obviously surrounded in terms of health and clinical experts. And then through kind of consent via kind of parents and guardians, we will then work with the young person on a personal development plan. And quite often that might then actually step away from the surgery environment as well. So what we try and do is set up mentoring sessions that are kind of comfortable in a safe and suitable environment to the young person. So that might well be a community setting, it might be at their school, or it might continue at the surgery if that's what they prefer. And really our mentors or youth workers are there to assist in terms of person-centered, so young person-focused goals, but also looking to link them into local services, whether that be kind of positive activities, whether that be additional support services through different kind of statutory support or kind of advice and guidance. And overall, we offer support for up to 6 months, and typically it will take place for about 1 hour per week. Next slide, please. I'm going to race through some of these, so we will be sharing the slides afterwards. So yeah, as I mentioned, in terms of the target group, young people affected by violence essentially, but there are lots of at-risk factors that we know are kind of linked in with that, and certainly with the kind of demographics of the young people we're focused on, that will kind of support that. And as you can see there, just in terms of the diagram, just looking in to link them with local services. And some of those potentially could be internally in terms of our own projects that we're running and our networks, but certainly externally as well. Next slide, please. I'm going to skip this one. Next slide, please. And through the work so far with Anna Freud, we have developed a theory of change for the model, as you can see there. I'm not going to talk through every single aspect of that, but I guess it's just some of the kind of theory behind what we're doing and how we're trying to do it, and also ultimately what sort of outcomes we will be looking to measure as part of the evaluation. And what we're really interested to look at is not just the kind of impact of the project, but there is also an opportunity to kind of compare a couple of different locations. So within the extension of the project, we're looking to move into different areas. So not just Newham, but other East London boroughs. So it'll be really interesting to kind of compare the different locations as well. Next slide, please. So just touching on some of the kind of the impact of what we've had so far. Clearly kind of young people are front and center of the project, and through some kind of qualitative work, we've recorded some of their feedback. Kind of themes that are coming from it are kind of that they recognize the non-judgmental environment, and they also recognize the fact that the young or they are supported by a non-clinical kind of member of staff. So that's kind of a youth worker focus, and that's something that they really value and appreciate. Yeah, as you can see there, just that kind of supportive network, I guess, in terms of what we can bring to it. Next slide, please. And again, I'll skip this one as well in the interest of time. And then again, just a little bit more kind of context in terms of some of the impact and certainly some of the learnings. So far we've seen 75% of young people have reported positive changes in behaviour, and they have reported those fairly quickly, so within the first point. So that's something that we're going to kind of look at in a bit more detail, and actually potentially there might be an opportunity there to maybe change some of the modelling in terms of that 6-month support. And yeah, there's a preference for face-to-face engagement, but we do use kind of virtual check-ins as a way to kind of keep that regular contact as much as anything. And I think there's also, in terms of the communications with GPs, we've learnt that some of those kind of reporting and updates and becoming embedded within their service is really important. So as an example, we've just kind of enabled our youth worker based within our Newham PCN. They've now got full access to kind of the data systems on the NHS side. EMIS is the system they use locally, which allows that kind of referral and update for them to update progress in terms of the young person much more effectively and efficiently. So again, it's kind of just kind of working through some of those systems to try and get that, or enable the youth worker or mentor to be really fully embedded within that the GP surgery and that network. Final slide, please. And in terms of moving forward, where we're trying to kind of, I guess, take it, as I said, we're looking to extend the pilot across East London, and we're in conversation with our next PCN site currently. And by the end of next year, we're looking to hopefully have just over 200 completers and our evaluation complete as well. And I guess that final point there, in terms of the broader youth violence strategies and networks, that's something that's really, we see as really, really important to this. And we see our role as, I guess, pivotal in that, in terms of actually, we know that through our programs, in terms of our wider community programs, we are in contact with young people who maybe have never stepped foot into a GP surgery or never even consider going to see their GP. So actually, there could be some really interesting work around actually how do we support them into accessing that service locally within their local area. And similarly, joining some of those networks together. So through some of our other community projects, we work with youth safety boards from the local authority. We're connected to the Met Police on various projects and programs. We sit in on the Intel sessions. So again, how do we actually utilize some of that insight and understanding to then bring it across in terms of that health sector and looking to kind of complement each other and make sure those young people are best supported. Final slide. It just has my details on, I think. There you go. So I will stop there.
Thanks so much, Jesse. Yeah, and good to have questions on your slide, because that's exactly what we're going to go into now. So we can ask those who are part of the panel to put your cameras on now. I can see there has been quite a few questions going into the chat, and also you'd be pleased to know, Jesse, quite a few suggestions for the name of your mentoring program, some of which you may not like. I should warn whoever put the comment about Arsenal, there are, I think, at least 2 West Ham supporters on the panel, but some quite interesting ideas there as well. Martha, I will hand over to you, I think, to chair this part of the session.
Yes, and I am one of those West Ham fans, so I'm not even going to say the suggested name. I'm just going to acknowledge that it exists, and you were joking anyway, and we'll move on. So has everyone got their camera on? Fantastic. Okay, so we've had some ton of really interesting information on a really broad topic. So first off, just want to say a big thank you to our panel and all of you for staying with us. So thank you very much. We've got lots of varied questions coming through in the Q&A. Please keep putting them in there. We'll try and get to as many as possible. There are some super specific ones that we may follow up on afterwards, just to let you know. But we're going to get through as many as possible. But first off, I'd like to actually open it up to Thea to kind of give us some reflections on some of the things that she's heard, particularly coming from a lived experience background. So yeah, Thea, do you want to give us some reflections and thoughts on what you've heard and any kind of key takeaways?
Yeah, hi. I would say for me, definitely a key takeaway is exercise and bringing that to the forefront, because it was definitely something that in one of my schools wasn't prioritized, and it kind of astounded me that it's not prioritized in all schools, and it has such a massive impact on young people when it's giving them the message that academics is all the focus is, and if we can do interventions that aren't necessarily relying on schools by doing it before school, I think that's something that definitely very much helped me in my experience of school.
Great, thank you. So I wanted to go to some of the questions in the Q&A now. There's quite a specific question in there from Stella around evidence related to separated parents. We don't have an answer for you on that one right now, just to say we will follow up after the session, so don't feel like we're not getting to that question that's popped up. So one question that's sort of come up in different ways that you did kind of touch on, Jesse, was around sort of the route into the mentoring program and GPs and engaging with young people, which you did mention may not necessarily be the right route. And on the back of that, a lot of people have asked about how young people are finding engaging with a mentor versus a sort of practitioner in the traditional sense. I'm wondering if you have any feedback or comment on that from people that have taken part.
Yeah, I'll kind of take that first point to start with. Yeah, we do recognise that, I guess, there potentially is a stigma attached to GPs and potentially the NHS with certain communities in terms of young people accessing it via the GPs. So I guess the model that we've designed, one of the USPs is around the fact that we are engaging with the health professionals, and they have a unique position within their communities for those communities and families they are engaging with. So I think that the kind of the I guess the model, the start of the model, the concept of the model came from that starting point. As it's now developed, we do recognise that there is a significant number of young people who that might not be the right route for them. So actually, in terms of the expansion of the project, that's something we're looking at in terms of how we can maybe diversify that referral process, and hopefully then connect those services together to actually, maybe if we build a trusting relationship with a young person who doesn't work with their GP or would never consider going to their GP, actually that might be something that positive kind of outcome that we could maybe support them with, and through that kind of trusted relationship with a mentor, actually help them to support access those services. And sorry, I've forgotten the second part. The second part was around
sort of how young people were finding the mentor-mentee relationship versus that more kind of traditional dealing with a clinician or a counsellor, and whether we had any sort of understanding of how they found that.
Yeah, so I think that probably the first point to make is that our youth workers mentors are not trained, they're not medically trained to support that kind of high needs of mental health issues or other issues. So part of the role is actually making sure and signposting young people into that support if that is what they need. And I guess, yeah, picking up on the point I made is kind of it's really kind of opening that door, isn't it? It's actually, you know, as a recognized brand linked, you know, with roots within the community, actually those young people might be more open to having an informal conversation with one of our mentors as that first point of contact, that first route in. But really our role within the program is really about understanding what that young person needs and then signposting them to the relevant support. And I think that's really crucial for our mentors to make sure that they're not taking that on themselves, because actually they're not trained to do that. So they need to recognize where that training, that support is.
That's great. Thank you, Jessie. I'll give you a break from talking now. I picked on you too much. Okay, so I think this can go out to Jess or Julian. We've got a question in the chat asking about the kind of metrics and measures that are being used in some of these projects that we're talking about. So I was wondering if one of you could speak to that, and then I'm going to ask a more broad research question. Don't worry, Dan.
Maybe you could both have a bit of a go at this. So for the Be Well project, for example, perhaps we can, I don't know if we can, I might be able to dig it out in a second and pop it in the chat that someone can put it in the somewhere publicly, but there is actually a link to the whole survey there, and it's really extensive. The kind of guiding principles for that one were that it was developed with young people to reference and priorities, but also that we used robust, well-validated tools, because we want to be able to trust what the findings are telling us, and that ideally they'd also be the kind of measures that are used elsewhere, so there's good read across to other studies, for example. So there we've got some kind of quite well used well-being measures, like for those who are measures nerds like me and some of the others on the panel, things like the Warwick and Edinburgh wellbeing, well, the short version of the Warwick and Edinburgh wellbeing scale, and some questions that come from ONS that are quite well used around wellbeing. Also some questions that come from other well-used surveys around social connections and so on. But actually, if we can put the link in, you can see the whole survey and it will tell you the origins of each of the sets of questions. Quite often we do go to sort of very tried and tested measures, just because there can be a tendency, particularly with things that are based in schools or communities, for people to create quite bespoke measures because they're thinking about the people in front of them. They feel like, you know, maybe that's a different population, but of course we want to have confidence that we're collecting outcome data that is reliable, that's valid. So we do tend to try and use something that's been well tried and tested before. I don't know, Julian, if you wanted to say anything else about measures used in some of your projects.
Yeah, certainly. And the point you were just saying about using existing measures, I think that also speaks to what Dan was showing in his study about how hard it can be to pull information across studies if people are using their own measures that they've developed. I think one thing that's really interesting in the On the Way to School project, it's how it's looking really kind of at the person rather than taking kind of necessarily just kind of snapshots of different constructs. So looking at amounts of physical activity, exertion, in addition to mental well-being and physical health. And there, I think we're also focused on kind of ability to engage with everyday activity. So not just about kind of how people are feeling, but how much they're able to kind of get on with the thing that they need to be getting on with. And I can't talk about measures without talking about a project that we're working on at the moment. You may have heard me talk about this one before. It will definitely be coming to one of these So What seminars in the future. But one thing we've really been focused on is how we can make measures more accessible, inclusive, and appropriate for children and young people. And as part of this, we've been doing a project to try and develop an image-based mental health measure for young people that isn't reliant on kind of text as our traditional measures. And yeah, we've been doing this kind of working with young people, co-researchers. So yeah, we're really excited with where that's going, and are just interested, as we're seeing with other projects, in just kind of how these different ways of seeing how people are doing relate to each other, and whether the prevention programs that we're talking about, you know, how do they affect these different outcomes? Is it a kind of domino effect? Does it impact them all at once? Yes, I'll pass back on to Martha.
Thanks both. That was a really fulsome answer. You're definitely outcome measures geeks. I wanted to kick it over to Dan now. And I think one thing we've kind of covered is there's definitely gaps in the evidence, and pulling together the studies for your paper was very difficult. Could you speak a bit more about like some of the gaps and where you feel they're at, and how we could potentially close them or approach them from a research perspective?
Yeah, sure, briefly. I think we really need to move away from just looking at kind of randomized controlled trials or controlled trials where it looks at was it effective, to include more kind of implementation science methodologies. So including kind of interviews to understand the mechanisms for the young people in these different settings, on whether the help seeking intervention is making a difference, and then also around that, what barriers and facilitators are also helping or hindering that. And then alongside that, as I touched on a bit on the sides, whether there's any theory involved and how theory is being used. And I think a good example of that was through Jesse's slides on the what's it called? I've forgotten the name of it now. I want to say theory of mind. It's not that one.
Logic model.
The logic model. That's it. So making sure that it's more robustly thought out than it might have been done so far. And then alongside that, really measuring fidelity of the model. So whether sessions were delivered as planned, or did things get in the way, such as clashes with school timetables or conflicting priorities in schools. It's only when we begin to take into account all of these other factors that we can actually really understand the impact of these interventions.
Great, thanks, Dan. And maybe one not to answer now, but we can follow up after is anyone on the panel aware of something that covers impact of parental interventions around prevention, including help seeking and that sort of thing?
There's a whole raft of parent-focused interventions, so I wouldn't like to stray too much, but because it's not completely my area of expertise. But there's a few sort of really well-known ones, like the Webster Stratton program, which is very much focused. These aren't necessarily help seeking, they're more general, but and another one is Triple P, which is also has quite a strong evidence base behind it. That there's probably whole stacks beyond that, but just to give a couple of examples off the top of my head, those would be the ones that come to mind.
And just to build on that, thinking about kind of outcome measures, please do check out the Cork website. Cork stands for Child Outcomes Research Consortium, because there we have a compendium of different measures, and there's one in there that springs to mind, which is the Brief Parental Efficacy Scale, and that looks at kind of parents and carers' confidence in supporting their children. So yeah, I just thought I would throw that in.
Thanks both. And I think that's definitely one we can follow up on post-event with some more detail on different interventions. So I want to open this up to everybody, because I think one of the really nice things is that everyone's presentations, while they were all so different, there was a real theme that ran through all of them, which was very much about meeting children and young people where they are, and being needs-led in the kind of approaches and the ways of thinking about these things. So I kind of wanted to open up to people to hear a bit more about that, but also to hear more about how we could be sharing this idea and giving examples of how we could give sort of broader advice to other people to take this approach in their work in children and young people's mental health prevention. And everyone is open to answer. Thea, if you've got anything to say here, I think you've probably got some thoughts about this.
Do you want me to go first, and then someone else can join in if they want? Yeah, I mean, I definitely say that obviously being driven both in like research and prevention interventions as well, being driven by what, you know, the young people are saying they need, and what they're communicating is definitely important, because I think sometimes children are kind of underestimated in how much they do understand their feelings and their experiences at school and things like that. And actually, you know, they have a lot to say. And very much when I was a young teenager, I still understood my experiences as much as adults kind of have a helpful perspective. I think being driven by young people is definitely key to getting this right.
I would agree with that, and I think when thinking about kind of what we can be doing to be needs-led, as Thea's saying, making sure we're asking that question of the children and young people, both that we're working with, but also to inform what we're doing, whether it's the service or the research that we're providing. And I guess I was also thinking about how important it is to, just from what you were saying, Thea, how important it is to try and arrive at that shared understanding of needs between the child and those, or young person and those supporting them, and how in kind of more clinical practice, there's often kind of talk about sort of formulations, which is trying to kind of paint a picture of sort of what's going on for the individual, what are their strengths and what are their needs. And I think one thing that we're really interested in, and I'm totally talking for you, Jess, for the work that you're developing, but what we're really interested in is how we can really bring the young person's voice into that, but also help them to paint that picture for themselves. So yeah, we've got a couple of pieces of work looking into that. One of the things we're doing, which you can see in one of our links to our previous So What seminars, is work on My Story and Me, which is a kind of storytelling prevention program that we've been kind of trying to develop. And yeah, this is all about kind of what you're saying there, putting the young person, the expert, at the center of articulating their needs.
What I'd also just add is that quite often someone's like core memories of something, or something that they really have held on to, can provide a lot of insight into their story and their experiences, and it might not be something that a parent or a teacher really thought of as a very significant moment, but in their life and their experience and their emotions, something very small can, that they might talk about, can give a lot of insight into what their needs are and what they are experiencing.
I could probably just build on that just a little bit as well, just in terms of to 100% agree in terms of the importance of the youth voice, and actually links into one of the questions that I did answer in terms of the project name, actually asking the young people, and that is something that we are planning to do. Ask our young person's steering group once they're set up. We haven't got it established just yet, but that's due to launch very soon. But also, I guess there's a point here around kind of accessibility of the service as well, and actually if we're reducing those barriers to accessibility, that's kind of crucial to getting to some of those young people that really need the service. Not through this mentoring project, but we have a number of different mentoring projects, and one of them is an offshoot of our KICS project, which is a community football based program. But actually through that project, the young people are participating in football, but then for those at risk and kind of that we feel would benefit, there is a mentoring support service attached to that. So that is kind of, you're building those relationships and trust with as a football coach, but then the role of that football coach needs to be able to be flexible to then actually it's much more a kind of supportive youth work mentor role as well. So that's something that's certainly a shift, I would say, in terms of some of our kind of typical sports-based provisions. Actually, there's recognition that actually those staff need to have a much more rounded skill set and much more kind of rooted in that kind of youth work ethos. I've gone off topic there, sorry, slightly.
Yeah, I was just thinking links to some of your prescribing work, Dan, as well. But I think what we're getting at is there's no one size fits all. I think we all know that the same thing isn't going to work for every young person. But I think when we look at the evidence base, sometimes we can get in our head that, you know, there is a silver bullet which will solve the problem, and, you know, this is the evidence-based approach. But when it comes to prevention, that kind of sense that it's, I mean, much as you said, Thea, it's different needs, but it's also different preferences and what young people will engage with, and that could be a whole variety of things. I'd be terrible at football, Jessie, but I like running. But yeah, there's all sorts of kind of different ways you can package prevention to make it appealing, and you can't really put all your eggs in one basket. It does have to be, I've got to start using this analogy because it's not the most glamorous. It is like Swiss cheese. You have to kind of have those different layers, because you're not going to catch everybody with the same approach, and in a way, meeting your people where they are is also about having varied provision within a place that meets some of that need, or all of it preferably.
I suppose just agree with all of that in terms of like a personalized care, social prescribing type of approach. It's what matters to you, and everything is then focused and shifted around that, be that the activity that you want to do, the type of person that you want to see, where you want to see that individual. So it all focuses and falls under that wider person-centered umbrella. I suppose the other thing just to bear in mind, though, is that it does sit in a wider system of increased kind of health inequalities within the society. So you can do all of the prevention work that you want, but actually we need to also think about how to change or drive the wider system to help prevent mental health difficulties as well. The onus is very much on the individual at the moment, and there is something to be said about the context and the wider system that this all works in.
All excellent and totally different answers. Well done. Thanks, guys. So we are nearly at the end, and I will hand back over to Jess now. But there was a really interesting point from Ro Rossiter I would draw everyone's attention to in the Q&A. And Jessie, don't worry, I'm going to share all of these name suggestions, but I think asking the young people's the best one, not the comment about Arsenal. So I just wanted to thank everybody on the panel and everybody for putting things in the Q&A before I hand back over to Jess to close us out.
Thanks so much, Martha. I'm trying not to get preoccupied with reading the comment. I will look at that in a minute. Yeah, I think this is one of my favourite topic areas. It's huge and so mind-bogglingly multifaceted. But it always amazes me how the themes, are so clear to me. Absolutely what we were saying about meeting young people where they are, and absolutely about a kind of place-based approach. So and I think some of these are just really nice examples of that. I think the other thing we're kind of centering on is it's a kind of freeing in a prevention context. Not everything that supports mental health at that early stage looks like a mental health intervention. It looks like football, it looks like the journey to school, it looks like exercise, it looks like a lesson in a school. And I think that's great because those are those are a whole range of ways that we can build mental health without sort of problematizing and pathologizing every young person. We can talk about building positive mental health, and we can talk about finding things that support your well-being and allow you to make social connections and find your support systems and find your help and so on. And I think I'm still mindful from what Dan presented that we can feel like we sort of have the solutions. The evidence base is really lagging in this area, particularly where we get these sort of quite complex and community-based and multifaceted approaches. They're quite hard to evidence, but that is the task. And trying to sort of build the evidence base around that is really, really crucial because, as you can see, we still need to shift that prevalence in the right direction. Yeah, so those are my sort of reflections. I would say Anna Freud more generally is thinking a lot about prevention and how we might do that differently. So do expect not just from these So What seminars, but do expect more from us, in the not too distant future around this topic. I think that's all I had to say to summarise. I do just want to thank everyone on the panel, particularly Thea for her reflections and for joining us and being up for having these conversations, but also to all those who presented and to Martha for chairing the discussion, and especially to Paula and the team that have been supporting in the background from our sort of events team who help us make sure everything runs smoothly. It definitely wouldn't if I was in charge of that. So thanks so much for everybody for that. Don't forget to check out our key findings booklets that I mentioned at the beginning and our research pages, and you can follow us on Twitter. And I should also mention that as you leave, you'll be provided with a sort of feedback link. Please do give us some feedback. We'd love to know what you want to hear more of, what you might want to hear less of, how we can do these better. We do them at least 3 times a year, so we're always thinking about ideas of how to improve. And thank you all for joining. I know it's it's getting late, so really appreciate you all being here and having the discussion with us. Thanks very much, everybody.